Good afternoon, and thank you for joining this fourth webcast on global budgeting for hospital services. This webcast will be focused on the global budgeting across the healthcare continuum. Joining me this afternoon are John Chessare. He's the president and CEO of the Greater Baltimore Medical Center and an early adopter of accountable care organizations. To his left is Jonathan Blum, and he is currently the executive vice president at CareFirst and also was the former director at CMS when the Maryland waiver was negotiated with Maryland. And finally, we have Vincent DeMarco, and he is the president of Maryland's Healthcare for All Coalition, which is comprised of 1,200 organizations dedicated to expanding access to affordable quality healthcare across the healthcare continuum. So thank you, gentlemen.
Thank you. Good to be here.
I am David Chin, a distinguished scholar at the School of Public Health and director of the Accountable Care Program for Value in Healthcare. Before we get started, I'd like to say a word of thanks to the Maryland Hospital Association, also for the American Hospital Association, with whom we've been collaborating to present this series. As I mentioned, this is the fourth in a series of webcasts on global budgets. The first was an overview of the global budget system, which is very innovative in the sense that hospitals are no longer rewarded for volume. Instead, they're rewarded for preventing hospital admissions, of decreasing preventable hospital admissions to the inpatient services. The second webcast was focused on a 4-year case study in which the Carroll Hospital Center in Westminster, Maryland, share how they spent some of the savings associated with this innovative system. The most recent webcast focused on how global budgeting might apply to healthcare systems around the country. And this one is focused on healthcare global budgeting across the continuum. The final webcast in the series, which will occur on December 18th, will focus on the federal perspective on the future of global budgeting across the United States. In terms of the format for this afternoon, we'll have some brief remarks, starting with John to my left, and then working around the table. And then we will then have time for questions and answers. And those comments or questions can be directed at any time to globalbudget at jhu.edu. That's globalbudget at jhu.edu, and those questions and comments will come right into the iPad here, and I'll be able to direct them to the panel. So with that, I'm going to turn it over to John to discuss your experience with global budgeting in Maryland.
Thanks, David. So our company, we're just one hospital, 250 beds. We have about 250 employed physicians, another 350 private practicing doctors that we work with, and we also have the largest hospice company in Maryland. We serve every day about 700 patients towards the end of life, most of them in their homes. And the global budget has been a great boon to us because back in 2010, we asked ourselves the question at a board visioning retreat, where should we go? Can we maintain our independence? Can we maintain our mission of serving our community? And we decided to commit to the triple aim of better health, better care, and lower cost. But for the first 4 years in that journey, every day I would go to the emergency department and get nervous because if we had actually taken steps to keep patients who didn't have emergencies out of the emergency department, I had to say to myself, where's the revenue going to come from? The good news now with the global budget is we can do the right thing and spend the money to generate better health outcomes, better care experience, and more joy for those providing the care. So we were among the first, we were in the first two groups in Maryland to create an accountable care organization. Mm-hmm. We've adopted the patient-centered medical home. We have 12 PCMH sites around the Baltimore County, which is basically the market that we serve. We're up a little bit north of the city. And we're very excited. 4 years in now with the global budget, we can actually spend the money to generate the triple aim. Mm-hmm. We've reduced Medicare costs by 11%, and just about every outcome we measure is improved. And our employed physician group, our patient-centered medical homes now are up in the top decile of the Press Ganey database and engagement. We've gone from being open maybe 8:30 to 5 Monday through Friday. Our offices are now open at least 7 to 7 and on Saturday and Sunday to try to generate the triple aim. And we're delighted that we now have a global budget and we can apply the money where we need to apply it.
Terrific. Jonathan?
Thanks for the opportunity. I think a couple of points just to add on to John's comments. First is from a CareFirst perspective, we have a huge interest to make sure that the waiver succeeds. That the state of Maryland was given a historic opportunity to test how to reduce the total cost of care for Medicare and all payers. And we have a huge interest from our members' perspective, from our customers' perspective, to ensure that the waiver succeeds. There has been phenomenal progress. Just for CareFirst membership, we have seen a decline in the last couple of years of 20% in the use of the hospital, meaning that we have 20% fewer people going to the hospital today than 5 years ago. We think there's many reasons for that decline, part of which is the new incentives that are created by the waiver. We try our best to organize CareFirst members to patient-centered medical homes, like the ones that John talked about, really to incent primary care physicians to take control of that patient, to ensure they're doing everything they can to care manage to prevent the hospital stay. And I think what is different in the last couple of months, certainly, is a whole new conversation that we're having with hospitals that want to be a partner back with the PCP to really try to avoid the hospital stay when necessary, to really plan with the PCP that discharge plan, to ensure that the post-hospital stays are coordinated, to ensure that medications get reconciled, but a whole different set of conversations now that CareFirst is having today than possibly 3 or 4 years ago when hospitals didn't face the same incentives. We are very eager to see the next phase of the waiver, to really understand how we're going to incorporate not just the hospital portion to do the global cap, but the total cost of care to the global cap. CareFirst really believes that the primary care, practice needs to be the center of that transformation, because they're in the best position to decide when patients go to the hospital, which specialists they see, which are the best hospitals for certain conditions. But overall, the first phase of the waiver has been phenomenally successful from our perspective. We have seen different patterns of care that we think is best for the patient, for CareFirst members. Now I think the question is how we get to the next phase. What does that look like, and how do we think about incorporating not just the hospital portion to the global cap, but the total cost of care? That's really the next direction for the waiver.
Vincent?
Thank you very much, Professor, and I want to thank Johns Hopkins for hosting this and for allowing us to be here, as well as Maryland Hospital Association, American Hospital Association. I'm honored to be here with GBMC and CareFirst, two real leaders in this state in making health system transformation work. We are very lucky to have top leadership in Maryland at the Hospital Association, Health Department, the Health Service Cost Review Commission, and Medical Society committed to making this work. And one of the things they understand is that the consumer, the patient, have to be involved in the process to make this work. And I was honored to be asked by the HSCRC to be the chair of the Consumer Outreach Task Force to really help the hospitals determine how best to work with the community. One of the first things we did was commission some focus groups to help us figure out how to talk about this. And what we learned is that what works is to really talk to people about this as a new day for healthcare in Maryland. That hospitals are now working with the community to keep people healthy. And we also held forums across the state, 11 of them, which were very, very successful. We worked with the folks at GBMC and Baltimore County, as well as all across the state, to hold these forums. And at these forums, 800 people came, including people from the NAACP, faith leaders, AARP, union leaders, businesses, providers. Everyone came to hear from the top state leadership about what's happening, and local hospitals and medical providers about what's being done. And then we had a conversation. What is the best way to move health system transformation forward in Maryland? And what we talked about at these forums at length was a new program we're talking about called the Faith Community Health Network, the Maryland Faith Community Health Network, which is modeled on a very successful project going on for the last 10 years in Memphis, Tennessee, that has brought hospitals and congregations together in a way that's improved health dramatically for the people in those congregations. They've seen drops in mortality, morbidity amongst the people who are part of it, and the hospital is so committed to this, they spend $600,000 a year of their community benefits money to make this program work, and they believe they save $4 million a year in reduced readmissions and other expenses saved. So we're working on bringing this to Maryland, and we're thrilled that LifeBridge Health, which includes Sinai, Northwest, and Carroll Hospital, have agreed to pilot this Faith Community Health Network in Maryland. And the pilot project is going extremely well. We have grants from local foundations to fund our work, and we have dozens of faith leaders in the area who are working with us to develop a plan. And what's happening is the hospitals are identifying people who will work with the congregations, and the congregations are identifying what we call liaisons, who will be there when someone from their congregation goes to the hospital. The navigator will talk to the liaison, so when they go home, there's someone there they trust that can help them connect to the care they need. We're going to have a training program in February to train all these liaisons, and we hope over the next few months and couple of years to really make this work at LifeBridge and then have it spread across the state and maybe across the nation. So we're very excited about this, and we're going to continue our forums, we're going to continue our outreach, and we believe health system transformation with consumer involvement can be a great success in Maryland.
Terrific. Well, it sounds like a very innovative program.
Yes, we're thrilled about it.
John, could you comment, you mentioned before that you have a critical mass of employed physicians.
Yes.
So you might probably also have a group of private medical staff who are not part of the employment group. How does that work under the global budget model?
It's a work in progress, David,
Okay.
I have to say. I think we have a core group of 18 private practicing primary care doctors who we've brought to the table. We've discussed the triple aim with them. They've signed our compact, and we are working hard to integrate with them. We use the meaningful use dollars to help them get the same electronic record that our employed doctors are using to make it easier to pass appropriate information back and forth between private practicing doctors and employed doctors. I think there's a lot of questions out there about the viability of the private practice of medicine into the future because the stakes are high around integration. So I think there's a lot of questioning going on. It has not been a linear movement. It's sort of been a group comes in, they feel us out, and then the next group wants to know a little bit more about us. I think that the regional information network sharing, CRISP, Chesapeake Regional Information Sharing for our patients, has been very helpful to help us get private practicing doctors connected with us. That movement has started. But I'd say it's really a work in progress. The transparency of data sharing helps when people see what we can do for them. The affiliated doctors that are formally in the ACO have the benefit of care managers that the ACO funds. I was a real-world private practicing doctor. It's very hard to manage the health of a population without helpers that know what they're doing, and our care management capability has been an attraction to the private practicing doctors because within the ACO we can legally share that resource with them to get the job done.
You mentioned compact. I think the audience might be interested in understanding what the nature of the compact is with private practice physicians.
So the good news about a big company is doctors come to work and on a minute-to-minute basis, they're not worried about paying the bills. Well, if you're in the private practice of medicine and you got 3 or 4 docs and you got 12 employees, you feel that on a given day, so that maybe you're not as focused in things like data analysis or keeping a registry of your diabetics or ensuring that your diabetics have all had their eyes examined, because it doesn't immediately affect you. So the compact says, yes, I'm committed to working on the triple aim. I'm committed to showing that my patients' outcomes are improving. I'm committed to showing that my patient satisfaction scores are going up. Yes, I'm committed to showing that I'm not wasting the community's resources on health care that is really not driving either better health or better care. So we formally engage them in that dialogue, we enroll them, and then they actually sign the compact before they join us.
Is there financial implications associated with that?
Within the ACO, there are no immediate financial implications. There's many contracts are aiding us as we move forward. CareFirst, we're very excited about what CareFirst has been doing. Many of the viewers may know in the Medicare Shared Savings Program, there's upside and downside risk. Our ACO is only in the upside side, so there is no immediate, or has been no immediate commitment of financial resources from the private practices, which I would argue has been an incentive for them to join us.
Terrific. And Jonathan, I know that CareFirst has been a real innovator in terms of patient-centered medical homes in this state. So you can comment in terms of how this global budgeting process helps that or takes advantage of that?
I think a couple things. First of all, the way that our program works is that we incent primary care physicians at a panel level, meaning a team of 10 physicians mostly, to take accountability, total cost accountability for their patients. It's shared savings similar to an ACO type financial model, but the goal is for the PCP panel to understand all the healthcare services that their patients are receiving, but also to identify gaps in care to ensure that those that need help can get help. CareFirst brings case managers to the practice to assist the physician to identify those members that could benefit from care coordination activities. So our PCMH model really is aligned around the same goals as the overall global budgeting system, to reduce care that's unnecessary, to ensure that the patient gets to the most cost efficient setting that produces the highest quality value. And so the CareFirst program was running before the waiver went into place, but I think what has happened is now that you have very similar sets of goals and incentives as we're trying to create for the PCMH practice as larger systems of care. So it's no longer, the counter force that we're trying to reduce unnecessary care, but others in the system might be trying to, continue the status quo. So I think what's different today than maybe 3 or 4 years ago is to really have the incentives aligned. Systems like GBMC have created, I think, primary care homes that are really trying to meet the incentives we're trying to create, at the same time meet the incentives of global policy. And so that's what's really changed. We haven't changed the fundamental tenets of our program, but what has changed is that we have many new partners coming to us wanting to work together to achieve the same goals to improve patient care, and that's the real difference right now.
Now, how do the primary care, I'm a primary care doc myself, and so how do the primary care docs deal with specialists and with things like ambulatory surgery centers that presumably still are based on volume as the incentive, not value?
Well, we take the premise that patients don't align themselves with one system or one, kind of healthcare system. They go to where their primary care believes they're going to get the best possible care. And so what we see in our data is tremendous differences in the cost of a patient going to one specialist versus another. The quality outcomes oftentimes the same, but tremendous cost differences because they're using more expensive procedures, more expensive facilities, more expensive testing than their peers. And what we try and do is to give that information back to the primaries so they can identify which of their specialists that they refer to tend to produce the higher quality, lower cost outcomes. They're not locked into any kind of referral. We have the broadest network in the marketplace, but we really try to incent the primary to choose those specialists that are also aligned with the goals of the care that we're trying to incent. So the primaries get that cost data from us. They can make the best quality determination, but then they can refer their patients to where they're going to get the best possible outcome and care. Oftentimes that's in the local community-based hospitals. Oftentimes that's in non-hospital settings. So we're trying to incent that. We're trying to give that information to the primaries to have them make the best possible judgments to where to refer their patients.
In terms of, you mentioned the patients, and the sounds like a terrific program to get at the 95% of the time the patients spend outside the acute care delivery system. So you could say more in terms of how that this faith initiative is leveraged, because it sounds like it could build very much on the programs that John and Jonathan have mentioned.
Yeah, let me tell you a little bit about what's happening so successfully in Memphis. They call it the Congregational Health Network.
Okay.
And they actually have a written covenant agreement.
So another kind of compact.
Yes, exactly. Between Memphis Methodist Hospital, which is doing this, and about 600 local congregations entered into a formal agreement. And each congregation identifies 2 or more people they call liaisons to work with the hospital, and asks their members to be part of this network. And they have over 20,000 individuals in the community who signed a piece of paper saying they're part of this network. They get a little card that says they're part of the network. And when they present at the hospital asks them, are you part of the Congregational Health Network? And if they are, the navigator in the hospital who's assigned to that congregation contacts the liaison. John Doe from your congregation is here. Now I want to emphasize something right here. The program, that program in Memphis and our program very much respects the privacy of the patient. So people don't sign that paper without first noticing HIPAA language, saying I'm okay with information being shared with the liaison in my congregation. And then when they come to the hospital, they're asked that again. Are you okay with this particular visit being shared with the liaison in your congregation? And assuming that's yes, then this dialogue commences. And what we found from faith leaders is one of the reasons they love this is that right now many times they don't know when one of their congregants goes to the hospital. Now they'll know right away. So they can alert their people in their congregation. And the navigator and the liaison talk about what John Doe needs while he's in the hospital. And then when he goes home, they create something they call a congregational care plan, where the people in a congregation, through the liaison, determine these are the things we could do. We could drive them to the doctor, we can mow their lawn, we can take care of their kids. And things like a patient will, as Mary Hopkins said, they prescribe certain pills and suddenly they can't afford them anymore. They want to cut them in half. They don't know what to do. They don't know how to call a hospital. They call their liaison. Is this a good thing? The liaison contacts the hospital. Can they do this? And they'll be told either to get back to the patient, don't you dare, we'll figure out a different way to help you, or it's okay in this case. But what happens is a trusted person in the community helps the patient and the former patient get the health support they need. We are thrilled to be bringing this to Maryland, and we've had meetings with the Maryland Hospital Association. Carmela Coyle from the Hospital Association really likes this program and invited Reverend Bobby Baker from Memphis to make a presentation to population health leaders from all the hospitals who heard about this. I have briefed GPMC leaders and many other hospitals, but we wanted a model in Maryland. We wanted a pilot, and LifeBridge has agreed to do that. And we are going to launch this in January with letters are going to go from the top leaders of denominations in Maryland, United Methodist, Presbyterian, Episcopalian, Catholic, Jewish, to their congregations in the LifeBridge area, alerting them that this is happening and asking them to be part of it. Then we're going to follow up with the congregation and say, did you get this letter from your bishop? Are you interested? How can we help you make it happen? And the hospital loves this. The hospital loves that we're doing this and that we're working together. And we believe it will really help healthcare in Maryland. And there are a couple of ways in which we're kind of building on what Memphis is doing. First of all, we're expanding beyond the relationship between the hospital and the patient to also encourage the congregation to learn how to get their people enrolled in the Affordable Care Act. The Maryland Health Connection, the Health Exchange people are working with us to educate them on how to do that. Plus, we want to educate them on broader public health issues. How to keep the people in your congregation healthy so they don't go to the hospital in the first place. And we're going to have monthly discussions with these liaisons to teach them about advanced directives, about the need for colonoscopies, how to keep people from smoking, alcohol abuse, and everything else. So we believe that this will work because fundamentally, in most congregations in Maryland and across the country, there are people there who have the health of their members as a top priority, but often they don't have the support to make it work. Now these people who are volunteers are going to have that support, and we think it's going to have tremendous public health and financial dividends for Maryland.
Can you say something about, because it's just starting, it hasn't started
Just
here in
starting.
Maryland. Say something about the investment required for LifeBridge to be the pilot, for instance. So we probably have a lot of viewers here wondering, gee, if I got a program like this started, what's it going to cost?
Well, that's an excellent question. Memphis Methodist Hospital does everything, soup to nuts, to
They
make
pay for
this work.
everything.
They pay for everything. And
Okay.
they told us that they spend $600,000 a year, which included having people recruiting congregations, which included training these liaisons
Yep.
and everything. Here, we, the Maryland Healthcare for All Coalition, are taking on a lot of that role. We're playing kind of the intermediary between the hospital and the faith community. So we applied and got grants from 4 local foundations: the Abel Foundation, the Stolman Foundation, Franz Merrick, and Blaustein Foundation, that have given us a 2-year grant,
Okay.
totaling around $300,000, which we are using to play that role of recruiting the congregations, and we have consultants who will help do that. And we're going to have training. We're going to have a seminar for to train these liaisons, and we're doing all that. The hospital, in its turn, is committing to have people on staff who will be there for the congregations. And I don't know exactly how much exact money they're putting into this, but they're putting in a substantial amount of time through their pastoral care team and through other people who will be there to help make sure that when someone comes in the hospital from one of these congregations, there's someone there who can talk to the congregation about giving the person the support they need. We are very excited about this. LifeBridge is very excited about it, and the faith community is very excited about it. And we hope that within a year or two, we'll be able to really demonstrate how this can be expanded throughout Maryland.
Sounds terrific.
We're excited about it. And if anybody wants, we have a website, healthcareforall.com.
Okay.
If you go to healthcareforall.com and look at health system transformation, you'll see all of this in there.
That's terrific. Can you comment, John, in terms of how the doctors, with this kind of potential, resource out in the community, how doctors and GBMC might be able to use something like this, or augmenting your existing? I know you have investment in infrastructure.
Absolutely. Let me start by saying that the global budget gives us the opportunity to create advanced primary care. I think most of the models in the country that have shown effectiveness have shown care management tightly connected to advanced primary care, because when the patient has a need at 7 p.m., they're looking for the provider. And the patients with chronic disease frequently wind up in the emergency department because the primary care system can't deal with their problem. Once they make it to the hospital, it's generally too late. What the global budget has allowed us to do is to fund advanced primary care, to embed care managers who are nurses, who get connected with people with chronic disease, and generally we start with the high utilizers, and those care managers are working with patients. It would be great to also have community liaisons if a patient was having a hard time understanding the care manager, so there is a fit here. Let me just give you an example. In 2011, as we were starting our ACO, if you said to me, gee, John, you're talking about diabetics. How many diabetic patients do you have? I had no idea. Today I know. We have 4,400 among our 65,000 patients in our advanced primary care centers. And each one of those, we know what their hemoglobin A1C is. And the ones that are out of line, they are coming to our educational sessions, and they all have care managers assigned to them. We're not getting direct reimbursement for any of that. that money to fund that is coming from the global budget. Before, we were focused on how many surgeries did you do? How many back surgeries did you do? How much money did you make? Now we're not focused on that any longer. We absolutely need a profit, but the profit is to fund better health and better care and to drive out the waste. So I think connections to further aid the most needy patients and maybe the most recalcitrant patients or patients that have real barriers that the healthcare system cannot directly affect would be a great add-on to advanced primary care.
Great.
Can all, each of you talk about, I think it's a great segue into how we get the patients more engaged with this? How do we explain global budgets in a way to the consumer, to patients that would
Can I?
make sense?
Well, I'm sorry.
So we could just go around. Each of you will have a shot at that question.
Go ahead. No, go ahead.
Well, we did these focus groups,
Yep.
and one of the things that our focus groups taught us is never talk about global budgets and fee
Okay.
for service when you're talking to the general public and
That's the
consumers.
first question. Yeah.
Never use those words. Number one, people will either not understand it, or number two, they'll be scared.
Okay.
Immediately they'll think, well, what happens when the global budget runs out? What if my surgery's in December? I'm not going to get anything.
Right.
It doesn't allow you to continue the conversation. A better way we have found is to say things like, this is a new day for healthcare in Maryland. Hospitals are working with the community to keep people healthy. And we actually believe that the very best way to kind of educate the broader public about health system transformation is through the lens of the Faith Community Health Network. In other words, think about either we're going to have earned media, press conferences, maybe even radio ads that will say hospitals in Maryland, LifeBridge and others, are working with local congregations to keep people healthy as an example of the new day in Maryland and health system transformation, so that people look at it as a specific way that this is happening. Similarly, a lot of things that Dr. Chessare is talking about are better ways to talk about this, as getting doctors advanced primary care for people so that they get what they need right away and don't have to come to the hospital. So the more specific you are in talking to people about what's happening, the better way it is to really educate consumers about this.
So I think one of the insights that we've had at CareFirst is that there are many barriers to care. And one of the hardest things to do is to get the patient to engage in a different care planning process and to really engage with the primary care physician, the nurse case manager. And I think a couple takeaways that we've taken is, number one is, even if you want the patient to, see the doctor more often, I mean, that's a cost share, that could be a burden. So for example, CareFirst right now is waiving certain cost-sharing services for CareFirst members who are in a formal care plan to encourage them to go to the doctor, so to kind of take that barrier away. Second is that it really matters that the primary care physician talks face-to-face to the patient to say, you need something different, or the nurse case manager says, you need something different. Processes that just rely on data algorithms to identify high-cost patients, then send a letter, those don't work. You really have to do a face-to-face interaction. You have to understand who those members are. They change month to month. They're not the same members last month they are this month. But to really have dynamic processes, number one, to find those members, but then to set up processes to have that face-to-face interaction, because that's what it takes really to get the patient patient to care, to comply. They don't care about global budgeting. They don't care about sort of the financial mechanisms. They want their care to be better, but you really have to think through how to engage them, and it really takes the primary care physician, the nurse case manager, to have that face-to-face conversation to say, this is how care is going to be going forward.
Good.
Absolutely, I agree with my colleagues that talk about global budget, and
Right.
the thing to do is to make it easier and
Yes.
to make it be value added to the patient. So if the patient is struggling with their diabetes, show them that these people are there to help and that they will actually benefit from it. We about 2 years ago we interviewed some of our patients and about the added, how they felt about the patient-centered medical home. And they didn't even know the term, nor did we expect them to know the term, but they all gave valedictory comments to the fact that they love their doctor and they love their doctor's team. And they couldn't believe that they were getting the added value of the care managers and nobody was sending them a bill for that. So I think it's very simple. Make it easier and make the patient experience it as a system. And that's what we strive to do every day. We're not a hospital company. We are a system of care, and we want the patient to experience us as a system. We would hope that they would never get near our hospital,
Right.
that somehow miraculously we could keep them away from the hospital forever. Of course, that is not going to happen, but if we can prevent half of the admissions, that's a great day for not only the individual patients, but for the community, the economy. God forbid that we give some of the money back and we help employers grow the rest of the economy.
Well, that's a good segue in terms of you have a direct connection to employers in this marketplace. Any sense of how they're feeling about it and what can be brought to bear? Because obviously these patients are spending a significant chunk of time at work as well.
Well, I think the employers that we work with, I mean, they have the obvious goal is to keep their workers healthy,
Sure.
To ensure they have the best possible care. They are very demanding that CareFirst or the healthcare system, finds members that have high needs, find patients that have high needs, really build that care plan. So I think, this change really is aligned with what the employer community wants. They want their workers to be healthy, they want the total cost of care to be less, obviously, and they put great demands on carriers like CareFirst to demonstrate what care management is being provided to their members. And so this is a very this change really is aligned with what I think the employer community wants. They want accountability, they want better results, they want lower costs, and they want their workers to be healthy.
Vincent, we know that the faith-based initiatives is a key cornerstone of your work. Are there other initiatives that would be important for the viewers of this webcast to understand in terms of engaging consumers and accountable care?
Absolutely. We held these 11 forums.
Yeah.
And after that, we presented a report to the Health Services Cost Review Commission, which is online on our website and on the HSCRC report. And we had a series of recommendations. One of them was to continue and build the Faith Community Health Network. Another was to build on these forums. Through these forums, we've identified 800 leaders in the community who each of them represent many, many thousands of other people in their organization. I'll give the NAACP as an example. They made sure there were people from their local chapters at virtually every one of these forums. And we want to go back to them after these forums and figure out what's happening. What are they seeing different, and what can we do to make this health system transformation work with them? So we want to continue to build on the success of these forums in the future. And then one of the things we learned from the forums, to build on what Jonathan and John have said, is the importance to the consumers of their primary care physicians' involvement in this. When we ask people, who are the kind of people you want to hear about this from, their faith leaders are one, and the primary care physicians. And we intend to work closely with the State Medical Society and other physician groups to make sure that primary care providers, physicians, nurses, everyone else, know what health system transformation is about and can discuss it with their with their patients. And also, we want to continue the broader education of the public about this and make sure they know about it, make sure consumers and patients, consumers who are patients also, know about what this means for them. So we're very excited about this. And the model that we're creating with the Faith Community Health Network is also a model that over time can be applied to more secular entities, more secular organizations. But we're trying it here first. We're going to make it work. And I believe in a couple of years we'll have a well-defined model which can be spread all over the state and maybe all over the country.
Can you comment, John and Jonathan, in terms of how, when we're talking about the care continuum, how to integrate public health agencies, home health agencies, skilled nursing facilities? Maybe we'll start with you, John, in terms of how to bring that all together?
Yeah, I think starting from seeing the larger system as a system of abundance is the right place to start. There's a lot of really good people out there. In our company, we have embedded geriatricians in nursing homes. We have a number of companies that we work with to try to assure that there's a connection, there's a direct connection between a patient who's in a nursing home and us or their primary care physician. The primary care physician may be a geriatrician. We do that. We have a contractual relationship with a number of home health companies, and we do the same thing with them. We try to connect as well as we can. We have, for patients for whom we are not the primary care provider, we have nurse navigators that go to the home to make sure that these patients are connected to whoever their home, their primary care doctor is, and if they don't have one, to help them find one. So our view of the world was we had to take care of what we already owned first, because and I think we've done a reasonable job of that, and now we are extending ourselves to as many people who want to work with us. I also will say that because of the gift of having Gilchrist Services in our company, we already have quite an extensive outreach capability for frail elders, and we've started a program called Support for Our Elders, where if people are not in the last 6 months of their life, they're not in hospice care, but they're too frail to come to primary care offices, we're now sending the nurse practitioners aligned with geriatricians directly to their homes.
It's a GBMC.
It's a GBMC program through Gilchrist Services.
One of the things that we hear from our primary care physicians is that, for example, they know their patients could use home care services, but they don't know who to refer their patients to. There's so many home health agencies, for example, here in the Baltimore area, they don't know who to call to provide that home care that their patient needs. One of the things that CareFirst does is tries to identify the best possible community resources to refer patients to who are in a care plan. We operate a system that we call the Service Request Hub, which means that when a primary care physician, nurse case manager feels that a patient could benefit from one of these community resources, we can connect that patient to the resource through our own process to make sure that the home health agency takes the phone call to say that the patient needs care, to make sure the home health agency responds within 24 hours. But we really see CareFirst role is to help make those connections. Number one, to identify the best possible community resources for home care, nursing home, diabetes management, but then to help connect the patient to those services once the PCP does make the referral, really to kind of take that burden off the PCP's practice, put it on us, and then also to make sure that that resource does follow up and provide that service in a very timely way.
Along those lines, is CareFirst employing disease management programs, things like that are complementary to this, and how does that work?
Sure. So what we try to do is we try to identify the best care management, care coordination program depending on the patient's own disease state. For those patients who have multiple chronic conditions, we have very formal care planning processes working with the PCP, working with the nurse case manager. For those members who are relatively healthy, but they have signs of developing chronic condition, we offer health coaches to help that patient develop goals, to better manage their weight, to better manage their smoking, to better manage other signs of growing chronic condition. But the goal really is to meet the patient where they are, to identify patients who have multiple chronic conditions that could benefit from very intensive care coordination for a relatively short duration of time, to those who are relatively healthy but they're trending in a bad way, that you can try to intervene early through a health coach, for example, and to stop or delay that disease progression.
Now, you among the panel probably have a unique perspective, being on the other side of the table with the waiver. There's a whole alphabet soup of innovations that are coming down the pike from CMS. Can you comment in terms of how those things might be compatible or not compatible with the global budget?
Well, I think it's a great question, and I think there is some confusion about which ACO model or bundle payment model kind of really fits where. But I think if you step back, they're really all pointing in a very similar direction to better manage patient care, to reduce unnecessary care, and I think what the opportunity of the state of Maryland has is to define the next phase of the waiver, but to define which tools will help achieve the next phase of the waiver, and to really incent that care. And I think the mistake sometimes is that we start with the financing, and that drives the delivery. And I think what all of us here, and I think in the community, are trying to do is to define the best possible delivery, then to build the financing structure around it. So I think that's the next challenge, really, to help define what the next phase to care delivery should be, and then figure out the best financing model behind it. CareFirst believes very strongly that the fee-for-service payment systems, continue to provide value. They continue to provide accountability. They continue to provide demonstration where's the best resource spent. So I don't see a scenario where we're going to, get rid of fee-for-service payment systems. We're definitely going to make payment over time much smarter, much more accountable, much more value-driven. But I think it would be a mistake to think that the fee-for-service payment mechanism will be phased out. They're certainly going to be better, smarter, more accountable over time. But I think that the first question should be, what's the best delivery of care model? Then how do you build the financing around it?
Well, that's a good segue in terms of a question that came up in the second webcast around integration of mental health care with the delivery system. I mean, Leslie Simmons really talked about the challenge of doing that. Could you all comment in terms of integration? Because that's obviously a huge component of patients with multiple chronic comorbid conditions.
Yeah, and it's not a surprise to anyone that when you look at a population of high utilizers, mental health is an issue for almost all of them. And what we've done is we work with Shepherd Pratt, our neighbors on the Hill in Towson. We are now embedding mental health providers into the patient-centered medical homes with the idea that if we could get at significant depression early, help a diabetic who's also depressed, we may have an effect not only on their mental health but also improve their physical health as well. It's a huge challenge. The fee-for-service world has brought us a very sad situation with serious mental health issues. We have at GBMC on any given day, we'll have 7 or 8 to even a dozen mental health patients living in our emergency department because there is no mental health bed. And the mental health system is fragmented, and there's a lot of reasons for that, but the single biggest reason is historically there hasn't been any money in it. And that's a sad indictment on the leaders of healthcare because most of our companies are not for profit. But it's an opportunity for us to rethink this, and I think with the waiver, again, the global budget, which is not a fee-for-service system, has given us the opportunity to take that resource and now maybe apply it a little bit where it should be applied.
So you say embed, so GBMC is funding
yes, we're putting
a psychiatric nurse practitioner, social worker?
We have psychiatrists right now. That is probably not a very efficient way to do it, but it was a place to start. Shepherd Pratt was willing to start with psychiatrists, and we hope to get to masters in social work and a more a richer system where mid-level mental health providers might be doing the bulk of the work and then referring the sicker patients on to psychiatrists.
Okay. Jonathan, comments about that?
Very similar approach and a very similar observation that those patients that have multiple chronic conditions often have other needs in addition to pure medical needs. We work with a company called Magellan Health that helps to provide resources for those patients that have more complicated substance abuse, mental health needs. We developed complementary care plans for those members to connect them to needed services. When patients are transitioning out of a mental health hospital stay, we try to engage that patient really to build a care plan that will best support them. But we wholeheartedly fully agree that we're not going to achieve the population health goals that we're trying to achieve without much better integration, much better connection, much better referrals to mental health resources that are timely, that are available, and that can complement the entire medical care plan.
Apart from embedding behavioral health workers into the patient-centered medical home, are there any innovations down the line that you can think of seen that might make sense and that get some traction in this area? Because it's obviously a very important area.
Well, I think it would be a great opportunity to work with other community agencies to try to construct a deeper and richer mental health system. Right now, there are so many handoffs of these patients, depending on the severity of illness. It's very, very difficult to make sure that the patient doesn't get lost in the handoff and sort of restart the entire process. It's something that primary care docs would never let happen. But these patients are not, there's really no managing function.
They're not connected. Yeah.
They're not connected.
Yeah.
So I'm not smart enough to come up with the innovation, but be happy to be at the table to help look for them.
Well, one of the things we heard in all of our 11 forums was the importance of behavioral health and mental health. Just over and over again, people commented on that. And there are a couple ways that we think the Faith Community Health Network can help with that. First of all, sometimes the spiritual help from the congregation can be of great assistance beyond the medical and mowing the lawn and everything. Just having the pastor, the rabbi, the imam, or the person who works in that congregation be there for the person. And secondly, our goal is to make sure these liaisons in the congregation know where the resources are. The hospital folks, we will provide them the information so that if they see that someone in their congregation has these needs, they will know where they should go. So in those two ways, I think that this Maryland Faith Community Health Network can help address this problem, building a lot on the great things that CareFirst and GBMC and the rest of the medical community and provider and carrier community is doing.
We only have a few minutes left, but I want to have you all comment on MACRA, the Medicare Access and Chip Reauthorization Act, which was signed by Obama in April of 2015. I mean, its stated goal is to change the way that physicians are reimbursed going forward over the next 10 years. So I wanted to get your take in the context of global budget, how this might fit or not fit in terms of what's going on. So we'll start with you, John.
I'll take a deep breath before I start on this one. Well, my belief is the next phase of the waiver, the challenge will be to bring the rest of the physician community in. And how precisely we do that, I'm not sure. I am a little concerned that the physician specialists are directly worried about the number of procedures they're doing, almost independent of the outcome, because that is where their livelihood comes from. I'll give you an example of orthopedics. We had to begin hiring orthopedists because, quite frankly, we couldn't get anybody to cover the emergency department. And a reason for that is that specialist orthopedists make their money doing elective procedures. We got to figure out how we can bring all the specialists to the table, have them have a joy in their profession, have them doing what they were trained to do and what they love to do, and better align it with the triple aim of better health, better care, and lower cost. And I think that's the big challenge. MACRA, it looks to me like it was great to stop this nonsense of every year trying to stop going over the cliff. On the other hand, it is very complex, and I'm very concerned that the physician community has no idea what all the rules are. It's a valiant attempt. It's a great step, but I think we're going to need to get some simplification of it. And I think the next phase of the waiver, smart people putting their heads together, may give another opportunity for Maryland to innovate and test maybe a slightly simpler system that brings everybody to the table to get us towards the triple aim.
Comments? I don't know if this was NACA was hatched during the time that you were at CMS or not.
Yeah, it was hatched after my time at CMS, and so I think it's going to be tremendously complex to build kind of separate payment models for different physician specialties. And so I think the opportunity that we see at CareFirst right now is for those kind of procedures and medical conditions that are treated by specialists, how do you really engage them to really support patients in the best possible way? And so the things that we're thinking about is how do you develop specialized care plans for those patients that have chronic kidney disease? How do you engage the specialist community to identify patients early in their disease progression, help primaries support those patients that have very specialized needs? So I think the opportunities will be for those conditions that are particularly acute, particularly high costs. How do you build payment models and process models to engage the physicians to help support the primaries, to delay and to prevent possibly the need for that procedure? And so we want to experiment with things like telemedicine. So when the primary is working with a patient that has a very difficult condition, how can you connect that primary to a specialist to either say refer now or don't refer, because you can manage that patient very well with your own resources, and that's where we want to get to in the next couple of years. And so I think the challenge will be how to kind of integrate that same process procedure to the overall global budget. But that's a great challenge to have.
You mentioned in terms of telemedicine and I guess we didn't talk about email and this kind of thing. I'm curious, in the focus groups, did that come up in terms of non-face-to-face, kind of asynchronous kinds of healthcare encounters as part of the solution?
Well,
or
people
not?
like face-to-face.
Okay, so that's reinforcing what Jonathan said, face-to-face.
Yeah, exactly what Jonathan said. And what both Jonathan and Jonathan said is very, very important. The consumers and the patients want to know from people they trust what is happening. Faith leader, the primary care physician, someone from the hospital who they trust. The more they have a trust relationship with the person talking to them, the better it is. And the more specific, again, we can be with what they can do and what their community can do to keep them healthy, that is better also. One specific thing that the focus group people loved was the idea that when you leave, you'll have your first prescription there with you. That the hospital will give you your first dose of your medicine, so you don't have to even go to the drugstore. Something specific like that, they really like.
That was very concrete.
Yeah, I was going to say I agree. Again, back to the trust issue and the face-to-face. But I think we need to be a little bit smarter with the technology. And what we're at GBMC by next year at this time, we will be doing FaceTime visits with smartphones, because we'll have the capability to do it. And it won't be with, I agree totally, it won't be with random people that they don't know. It'll be with their primary care team. So we don't want, in a value-driven system, we don't want to visit if we don't need a visit. But if we need to have a conversation with somebody and we know that the patient is looking to us because they trust us, maybe we could do FaceTime visits and save time and resources, but have that interaction to make sure that the primary care provider or the care manager and the patient are in lockstep.
Good.
That sounds like a GBMC app coming down.
It's not a GBMC app, but I don't want to mention the name of the vendor to get anybody in trouble.
Yeah.
And again, the liaison of the congregation can be that face, so the person feels comfortable connecting in other ways with the provider and the hospital, so that there's someone who they've known for years who validates what the providers are telling them.
Well, thank you very much. We're running. This hour has gone by very quickly. So please join me in thanking John, Jonathan, and Vincent for a very engaging hour on the global budget and the care continuum. As I mentioned earlier, the fifth and final webcast will occur on December 18th from 1:30 to 1 to 2 o'clock, or sorry, 11:30 to 12:30 Eastern Time. And joining me will be Patrick Conway. He's currently the interim principal deputy administrator at CMS and is also the chief medical officer at CMS. And he is going to give us a perspective in terms of the future from the federal perspective on global budgets. So please join me on that webcast again on December 18th from 11:30 a.m. to 12:30 p.m. Eastern Time. And in the meantime, if you have any questions or comments about this webcast or earlier ones, please feel free to send them at globalbudget@jhu.edu. Thanks very much.